for our webinar today. On behalf of the California Institute for Mental Health and in collaboration with the Alcohol and Drug Policy Institute and the Integrated Behavioral Health Project, we would like to welcome you to the first of a six-part webinar series titled Integrating Primary Care, Mental Health, and Substance Use Services. The goal of this webinar series is to provide information on critical policy, design, financing, and practice issues related to integrated care from the national and the California perspective. Presentations will cover best practices and emerging practices in the field, as well as really help to hopefully move forward all of our work in improving health outcomes for people with mental health and substance use issues. And just to give a couple of technical details, to reiterate, these webinars are free and are open to all. They are held from noon till 1:30 on the dates that are indicated in the schedule, which is posted on the CIMH website. To view the schedule or to register for future webinars, go to the CIMH conference link, click on Learning, and then under Online Learning you will find our webcast. You must register online for each webinar that you wish to attend. Webinars will also be posted on the CIMH Integration Initiatives webpage following each event. And we will send out an announcement to all of you who have signed up for this webinar so that you'll have the link to the recorded version. So just to announce the faculty for today and the facilitators, my name is Gail Bataille, and I'm an Emeritus Mental Health Director and CIMH Consultant and Coordinator for our integration initiatives. Victor Kogler, who is the Executive Director of the Alcohol and Drug Policy Institute, will be joining you at the later part of the webinar and will be assisting with the question and answer session. So I really want to thank Victor. Our topic for today is integrating the case for integration. And we are really delighted to have Barbara Maurer, who is an MSW and a principal consultant with MCPP Healthcare Consulting and with the National Council for Community Behavioral Healthcare. Barbara has been a national leader in bringing to light the impact of inadequate health care on persons with serious mental illness and substance use disorders, and in advocating for integrating primary care, mental health, and substance use services. Barbara was the principal consultant for California's Integration Policy Initiative, the IPI project. Our second faculty is Dr. Connie Weisner, and she is with the Division of Research for Kaiser Permanente and has conducted research and presented and published widely on the benefits for individuals and their families for ensuring integrated access to screening and intervention and treatment for substance use and abuse. So just on to how this webinar will work, and then we'll turn it over to our faculty. Our presentation is structured to provide a brief break following the first several major sections where audience members can pose questions or send comments on the material that has been presented. During the presentation portion of this webinar, we will only accept written questions. And to do that, you simply type your question and click Submit in the dialog box. At the end of the formal presentations, our presenters will respond to additional questions. If you experience technical difficulties, please contact our organizer, May Chan, and she can be contacted at mchan@cimh.org. We've had a really wonderful response to this webinar with well over 200 participants. And so we apologize in advance that we may not be able to get to all of your questions and comments, but we will create a frequently asked question response for grouping the questions that we cannot respond to directly during the webinar. So please do not hesitate to send them in. So thank you very much for joining us today. And before we move into the formal presentation, I would like to take just a moment to dedicate this webinar to Michael J. Oprendeck, Mental Health Director of Solano County. Mike recently passed away at far too young an age, but he was a passionate and compassionate advocate for mental health consumers, including for their right to live full and healthy lives. And so at this point, we will begin our presentation on the case for integration, and Barbara Maurer will start the presentation. Thank you all very much.
Thank you, Gail. It is a pleasure to be with you today and to be doing this with Connie. And what we want to do is take you through some of the research that supports the case for integrated care, because we think it's very important that we be able to make that case in policy discussions at both the local, state, and national level. So I'm going to get us started by putting some context out there for you. Some of you may have heard this information before, but it's really important for us to take a look at how healthcare reform sets us up to tackle the issues of integration. And then we'll specifically have an entire section that Connie will present on substance use conditions and healthcare. I'll go through quadrants 1 and 3 of the 4-quadrant model, and we'll stop at that point and take questions about everything that has been discussed thus far, and then come back and talk about the 4-quadrant model, quadrants 2 and 4, and a bit about California developments and opportunities. So let's start with the impact of healthcare reform, and the fact that there are several pieces here that will be coming together to create an unprecedented opportunity to offer mental health and substance use services to individuals who may not have had access to them before. The first thing is the expansion of Medicaid. We are looking at roughly a 1/3 increase in Medicaid enrollees across the country. That varies from state to state depending on what their previous eligibility requirements have been, but essentially single adults who have an income under 133% of the federal poverty level will be eligible to be covered by Medicaid simply due to their income levels. It will not be necessary for them to have a disability assessment in order to be on Medicaid. For individuals who are between 133% of poverty and 400%, they will be able to get coverage through state exchanges, and those state exchanges will provide subsidies for people based on their income. Now, importantly, at the same time that all of this is happening, this coverage expansion, we have the implementation of parity for mental health and substance use services. And it's a coming together of all of these streams of parity, some of which has been in the health reform legislation itself, that puts mental health and substance use services into the benefit package and establishes an expectation of parity. The benchmark benefit package that you see referenced here will be the basis for coverage in both the Medicaid expansion plans and the exchange plans. And again, mental health and substance use are included in the definition of essential health benefits. So this gives us a new world as we move into 2014 that we need to begin preparing for, because there will be a lot more people who will be able to access services. One of the other key themes in the health reform discussion has been delivery system redesign, and one of the big pieces of that is the idea of the patient-centered medical home. And that is being driven by the fact that 45% of Americans have one or more chronic conditions. Treating these conditions accounts for 75% of the direct medical care in the country, and over half of the people receive their care from 3 or more physicians who generally have not coordinated the care that has been provided. So the idea of having a patient-centered medical home where there is an accountability for understanding all of what is going on in a person's health care and helping them with managing that care is a key strategy. The patient-centered medical home has a number of principles that it's founded on. One of them is an ongoing relationship with a primary care provider. But a second very important thing is that it shifts the idea to having a care team. So it's not just your primary care doc, it's the other members of that physician's care team who are collectively taking responsibility for your care and either providing that care or making appropriate referrals, assuring that it's coordinated and or integrated, always being attentive to the issues of quality and safety, ensuring access as in enhanced kinds of ways. And finally, one of the big pieces of this is to pay differently for patient-centered medical homes in order to build a robust primary care system in this country. Now, for those of you who want to know a whole lot more about the patient-centered medical home, you'll see a website down at the bottom of this slide. That's the website for the Patient-Centered Primary Care Collaborative, where much of the analysis, idea development, and planning for the future is going on. You can find lots of good information on their website. One of the things that has already been underway are some studies in looking at what it takes to transition from current practice models in primary care to the patient-centered medical home. And this important article that came out last year, which looked at 36 family practice settings who were in a 2-year practice transformation project to become patient-centered medical homes, identified the fact, just to cut to the chase of these 6 points, it's not easy. This is not easy work because it really is about changing the way the work is done and using different kinds of tools, including IT tools, working in a team kind of environment, and it means that you really have to work with a great deal of focus developmentally in your organization. And finally, it's a local process. Dale Jarvis, who's my business partner, and I are fond of telling you that all healthcare is local, but in the end, these kinds of things need to get worked out locally. The important thing about integration is when we look at the challenges that are being faced with the patient-centered medical home transition, we need to weave the integration of mental health and substance use into those transformations, because that's also about changing personal and organization practice in the context of local relationships. So these things, the more they can be woven together and implemented together, that will be less confusing, I think, for folks. The patient-centered medical home needs mental health and substance use treatment capacity, and between Connie and myself, we're going to show you a lot more data about that. But this particular report is one that got a lot of attention when it came out last fall, because it tells us that across the country, when you look at all Medicaid beneficiaries who have disabilities, 49% of them have a psychiatric illness. And if you look at the chart, you will see that in the diagnostic dyads that were analyzed in terms of their cost and frequency, that psychiatry is a co-occurring illness in 3 of the 5 top dyads. So that really got people's attention. Now, the substance use piece doesn't show up in this study because it was an analysis of claims and pharmacy scripts. And as we know, much of the substance use treatment that happens in this country doesn't happen under a Medicaid encounter. And so that information is not presently available to us, but it's the kind of information we hope to gather in the future. The work that the National Council has done on this transition and healthcare reform has focused on trying to think about how do we coordinate with the patient-centered medical home movement, and how do we make it clear that mental health and substance use services need to be a part of this movement. It was not at all clearly articulated in the initial models that were developed for the patient-centered medical home. So we've suggested that changing the name of this to the person-centered healthcare home signals that mental health and substance use is a central part of healthcare, and that healthcare includes a focus on supporting goals for improved self-management. We have advocated for a bidirectional approach in which we would integrate primary care services into mental health and substance use settings, as well as placing mental health and substance use services in primary care settings. And one of the structural ideas for doing that in both directions is to use the idea of the care manager or behavioral health consultant and consulting prescribers to help support the primary care activity. You're going to see a lot more about this idea as we go through the 4-quadrant model. Integrated care, a definition. There's lots of definitions out there, but this one I think is a very helpful one. It focuses on the idea that physical and behavioral health problems often occur at the same time, and that integrating services to treat both will yield the best results and be the most acceptable and effective approach for those being served. So the question is not whether to integrate, but how. And we know that neither primary care nor behavioral health providers are currently trained to address both issues. So this webinar series is intended to begin to address this question of how. So let's now shift and specifically look at substance use conditions and health care. And I'm going to turn the talking over to Connie at this point. So Connie, are you there and ready to go?
I am. Thank you very much, Barbara. And I assume everyone can hear me. I really appreciate the opportunity to bring research on substance use conditions and health care into the picture here. I'm going to talk about why primary care is important and thinking about a medical home, what the substance use population looks like, and in terms of cost to health care, especially after treatment, substance use outcomes when there's integrated care, and both when integrated care is both with mental health and primary care. So this slide is a triangle that many of you have probably already seen, but I think it really helps us put what the substance use conditions into a perspective when we're thinking about a primary care medical home. And it reminds us that at the very top of the triangle is actually the very small proportion of people who have really severe substance use problems that require specialty care. Yet that is where we as a society have put the emphasis of treatment. The second group down is people actually who have severe problems, who need some kind of services, maybe not in specialty care, maybe more though than brief interventions though, that can be managed either in specialty care or possibly in special modules in primary care. Then we have a large group of risky drinkers and drug users, or unhealthy use as it's called here, and then little or no substance use is really the group that we want to focus on in terms of prevention. But all of these conditions add to our overall health care costs. Although I'm not going to show data on this today, I want to point out that even research that we have done in primary care among hazardous drinkers and drug users has shown that those individuals have higher rates of medical conditions than other matched members in Kaiser. When we match them on age, sex, catchment area, geographic, a census block kind of matching, and as well as prone being utilizers, that basically they have higher rates of medical conditions and also higher costs than the non-hazardous users. Next slide, please. Next slide.
It takes a moment for it to come up. Is it there now?
Okay.
It's the cyberspace piece of it.
Okay, thank you. So I'm going to be showing some data from Kaiser. And the reason that the data are interesting here is even though it is a middle class, working class population, it gives us an opportunity to probably take a conservative look actually at the findings, and it gives us access to utilization and cost data. So it's an interesting laboratory to look at some of the issues related to the costs of care and potential integration models. So these the studies I'm going to be reporting from here are on the whole either randomized studies or observational studies looking at membership data. And the next points here really point out that I don't care what study we've done. I know that the same thing has happened in the public sector. We find that that individuals entering substance use treatment have higher medical costs than other health plan members, and that those costs go down after treatment. Here in one of our studies, where 18 months post-treatment, there was a 26% reduction in cost. And I want to point out that almost all of the cost reduction happens in emergency room and in hospital utilization, which we call inappropriate utilization. We do not necessarily find huge reductions in primary care, nor would we really want to, because as you're going to see later, actually increasing primary care visits has good outcomes both in terms of clinical effectiveness and in costs. Also, when we do this research, we are always looking like for 1 or 2 years prior to treatment and at least 18 months after treatment, so that we are getting away from any cost reductions that we see that are based on really high costs just prior to entering treatment. That car accident or whatever it was that causes a spike in healthcare costs prior to treatment. Next slide, please. So we're focusing today on the role of integrating services, and so I want to talk about it first during treatment. And as you will see in a minute, the majority of people entering treatment, even in a place like Kaiser where there is access to health care, most of those people have high rates of medical and psychiatric medical conditions, which we have called substance abuse medical conditions. And those individuals, in a randomized study we did, who received their primary care integrated with their substance use treatment, were twice as likely to be abstinent 6 months after treatment. And we're finding when we follow those people at 5 years, even those people who had integrated care were more likely to be abstinent 5 years after treatment. And I believe our hunch about this is that they had really learned more about medical conditions and about how to use medical care. Next slide, please. But because of the fact that people need services much more past that one episode of treatment, we have been really looking at how we might think about continuing care that is based in primary care as a medical home and look at its effect on remission. And the way we have defined that is that individuals should have substance use treatment when needed. They should have psychiatric services when needed. And I wanted to just step back for one moment and say that although I'm really focusing more on the integration with medical care in this particular talk, that we have found across the board on all of our studies that individuals who have received sufficient psychiatric services during treatment and, as we're seeing here, over time, are much more likely to be abstinent even up to 5 years after substance use treatment. And we're finding even reductions in cost for those individuals with high psychiatric severity as they entered treatment. For example, those with high psychiatric severity had $1,000 per member per month cost, which reduced to about $300 per member per month at 5 years. This is an enormous reduction, and again, most of this came from emergency room and inpatient care. So stepping back now to our continuing care model, in addition to substance use treatment when needed and psychiatric services when needed, our approach has been to think of individuals needing a primary care visit at least every year. So we have been following patients entering treatment and looking at their utilization for over 9 years. And we're finding that people who received continuing care, as I've defined it here, are more than twice as likely to be in remission of their alcohol and drug problems at 5 years. At each point, and we've interviewed them every 2 years, and at each point at which we interviewed them, when they had continuing care, the period before that, that means they had a substance use readmission if they needed it, they had psychiatric services if they needed them, and a primary care visit every year, then they were at that following point more likely to be remitted. And they were also less likely to have emergency room visits and hospitalizations. So, and that was even if they were not in remission. So it was actually affecting their costs even if they were not in remission. And just in case you're interested, the way we have defined substance use treatment when needed and psychiatric services when needed is by, from our interview data, individuals, we ask a lot of questions, including the Addiction Severity Index. So we took a very conservative approach. Anyone who had anything above a 0 on the Addiction Severity Index, if you're familiar with that, in other words, any use at all, any problems at all, we defined them as needing either substance use treatment or psychiatric services. Next slide. Another study that another point that I wanted to make in terms of healthcare costs has to do with the family members of individuals with substance use conditions, and this speaks to the importance of screening in primary care. We were able to take 1,500 patients who were in our studies, and using the Kaiser data, pull their family members' data, so that we were actually able to identify the family members of people with substance use problems within the Northern California Kaiser region. And we found that before treatment, family members of all the substance use patients had higher medical costs than control families. And the families were matched again on age, sex, geographic area, and beginning utilization. And they had both the adults and the children members had significantly higher prevalence of many high-cost medical conditions compared with the matched members. And that was for both spouses and children. And what I don't have up here is that we have also shown that when we compared family members with family members of other chronic disease, patients with other chronic diseases, including diabetes and asthma, that their costs, the family members of those with substance use disorders, also had higher costs than family members with those other chronic conditions. What was really important, we then looked at the family members of people who had successful treatment. In other words, individuals who who were abstinent at 1 year. And when we looked at the family members of people who were abstinent at 1 year, their costs were significantly reduced starting that second year, and we've looked at it through 5 years. They are no longer different than the cost for the matched controls. However, the family members of substance use patients who were not abstinent at 1 year had a trajectory of increasing medical costs relative to the control group. So in terms of our building a business case for an active approach in primary care, I think it's important to note that there are family members' costs and quality of life, their medical conditions that are at risk here. And it really argues for identifying individuals earlier in the course of their disease so that they can receive services earlier. And it certainly also is a message that we need to do a good job in providing services so that people are successful. Next slide, please. So this slide just steps back a little bit to show you the medical conditions that individuals with substance use problems have, those that are really the severe group entering treatment. It's a long list. These are high costs, and it's a really important reason that they need continuing care in primary care. These individuals have, as we found in our studies, as the last point here shows that there was a significant decrease in inpatient and average medical costs, including substance use treatment for individuals who received integrated care. The way our system is set up now, even often in an integrated health plan, once someone enters substance use treatment, that sort of becomes their medical home. They're identified as a substance user, and we do not always pay adequate attention to their other medical and mental health conditions, and this can then be related to relapse and certainly higher costs. Next slide, please. Actually, could we go 2 slides past, because I have, unfortunately, a repeat here. Oh, and I think, Barbara, you were going to talk about this slide.
Right. Did I skip past one you wanted to do?
No, that was good to skip that.
Okay. So this is just a very brief compilation of a number of studies that Washington State did looking at substance use treatment and expenses for health care in the Medicaid population. So Connie's just been talking with you about the Kaiser population. Now we're looking at the Medicaid population. And what they found in tracking Medicaid cost differences for those who received treatment and those who did not, and treatment here could be defined as anywhere on the continuum of treatment. It could be outpatient, it could be intensive outpatient, it could be residential, it could be methadone maintenance. The average medical costs were $414 a month higher for those not receiving treatment. And even when you added then the cost of treatment in for those who went into treatment, there was a net cost offset of $3,000 per year. What's interesting to me about their data is they also did some stratification beyond that. So if there was an overall net cost offset of $252 per month, if people went into treatment, we see that the cost offset rose to $363 per month if they completed treatment. We also see here that if you are doing treatment in a methadone maintenance setting, for those recipients, their cost offsets rose to $899 per month if they were remaining for at least 1 year. So you begin to see entering treatment, completing treatment, long-term methadone maintenance, and the impact on healthcare costs. They also, in Washington, have been tracking emergency department costs paid for by Medicaid, and for those who were treated, they found that the number of visits was 19% lower, cost was 29% lower, so that almost offset the average monthly cost of treatment. But for a subset of emergency department users, those who had 12 or more visits a year, there was a 17% reduction in costs for those who entered but didn't complete treatment, and a 48% reduction for those who did complete treatment. So part of what we learned from looking at this data is that it's important to get people into treatment. It's even more important to figure out ways to help them retain in treatment and complete treatment, and it does pay off in terms of healthcare costs if you can do that. So Connie, did you want to come back to this, or did you want me to go forward with these?
That's fine. Thank you. So the this slide is really reminding us, or setting the stage for talking about the opportunities that we have in primary care now, that there is a great deal of diffusion of screening and brief intervention underway. A great deal of research and demonstration projects have shown us that motivational interviewing with fidelity is an important component of screening and brief intervention, and repeated brief intervention in primary care is a promising practice. And in our field, we are having a very exciting moment where we are really finding an expansion of medication-assisted therapies in primary care that can be expanded. So with that context, let me talk to you about how, one way of starting to think about a model of integrating and primary care and substance use treatment during treatment and a continuing care model. Next slide, please.
Oops, I went too far. Let me go back.
No, that's just fine. No, that's fine. Okay, thank you. The way I'm thinking about this and studying it these days has to do with thinking about this chronic condition of substance use and looking at it the way we look at disease management for other medical conditions, such as diabetes. And the way that would make sense under this kind of approach would be that we would do screening and brief intervention and including treatment in primary care if it is a moderate problem, and continuing monitoring there. However, If it is a severe problem, then people are referred to specialty care. And after that, specialty care, after they're stabilized, they're referred back to primary care for monitoring. This is the way the disease management for many other health conditions is handled. Next slide, please. Before I talk about how we are a model that we're looking at, I want to bring us back to the public sector for just a moment to show that there is some evidence that this is important, that this is doable and important in public populations. This is work that happened in Massachusetts. The important thing is linking people with primary care back to linking people with substance use problems after treatment to primary care. And this is a very simple intervention that was done where people were linked to primary care after detox. There was a medical and social work team in detox that did this, and it was actually just made an appointment in a public primary care clinic and sent a letter to the primary care provider. That was all that was done. And yet there were more people who actually then did keep their primary care appointment, 69% versus 53%. And importantly, when patients were followed over 5 years, those people who had more primary care visits had better drug and alcohol outcomes. So we're finding, just as we found in the Kaiser data, that having ongoing primary care visits, especially after that linkage is made, has good outcomes. And both in that study and in our studies, we don't know what happened. We don't know exactly how this happened, but in terms of whether the primary care physicians were activated or not, what we do know from some of the Kaiser data is that the Kaiser physicians didn't even know the person had been in treatment. But I think just dealing with the medical conditions that these individuals have is important. Next slide, please. So we have, we're thinking about how to do this. There's in having a continuing care, integrated care based in primary care following substance use treatment. And there's two basic approaches. One would be continue to train primary care providers to screen for problems, and especially in those who have been in treatment or diagnosed. And the question is, is this doable? We are, some primary care physicians are very, very busy. They have, we have been doing a lot of training in our field through expert and so forth to train people to screen, and it's just not, I don't know if we can always count on that happening. The other approach is, again, borrowing from disease management and thinking of our patients with chronic conditions is the patient empowerment approach that would, empower people. It would activate them. It educates them about the importance of managing their substance use problems, similar to medical problems. So we're talking about adding, while someone is in substance use treatment, groups on thinking of yourself as a whole person, not just as a substance abuser, but you need flu shots, you need mammograms, you need all the other kinds of things that would keep you happy, how to talk to your doctor, and how, really addressing some of the issues of stigma and communication, how to raise the issue with providers. Very importantly, as we've been piloting some of these things, I just want to, point out a few little things that have made a difference with the patients, is having a physician come in and talk in part of these groups, talking about the fact that they never see the people who are doing well, and that when they do know someone has been in treatment and they are trying to take care of themselves, that they feel very motivated to help these patients. So I know we have a long way to go in our field to address stigma. Our patients are not activated or feeling empowered the way people are with other chronic diseases, but they are going to be dealing with physicians in many different health systems and in many different situations, and I think it is time that we start thinking about how to approaches to empower them. So next slide, please. So as I mentioned, here is some of the things that we are trying, and and I believe would love to work with some of the with some public programs on as well, in terms of having group sessions, as I said, on lifestyle practices, on screening and immunizations, and as well as educating them about the health conditions that they have that are related to their substance abuse, which is usually all that people get. Talk about selecting a primary care physician and communicating with him, and then having a linkage phone call with a patient, a clinician in the program, and the physician, just saying, Mr. Smith is in treatment, doing well. We'd like you to give him a medical visit while he's in treatment, and follow up. And each time he comes in, ask him how he's doing with his alcohol and drug use. If you have any issues at all, how to handle it, call us back for a consult, or send them back to us. And if there's time in the question-answer period, I have a lot of ideas on how to do this in public systems at all, especially with all the opportunities that Barbara discussed at the beginning that are now there with health reform and the possibilities that are there. And I really am seeing the physician intervention as a minimal part of this. We are really training the patients rather than the physicians. We would be mainly briefly letting physicians know that they will be getting phone calls and appointments to talk to these patients, and that they can call someone at the substance use treatment program back if they have any issues. So just reiterating that we're really thinking, I think our field is thinking about how to place substance use problems in the context of overall health and health care, and increase patients' involvement in their own care. Thank you.
Thank you, Connie. That was really terrific. This is just such important information that Kaiser has been generating, and it gives us lots of ideas about how to think about the public sector and how to do this work. I'm going to talk now very briefly about the 4-quadrant model and quadrants 1 and 3. I think probably most of the people who are on this call have become familiar with the 4-quadrant model. The idea here is that you're planning for a population, and within any given population, you are going to have subpopulations that exist because of the crosswalk of mental health and substance use risk and complexity and physical health risk and complexity. So the vertical axis here is mental health and substance use risk and complexity. The horizontal axis is physical health risk and complexity. And the reason for using this as a planning tool is that what the services are, who the staff are that are delivering them, what the skill sets are that they need to deliver those services, and what's the context for the service will vary in each of these 4 quadrants. And so I'm going to talk first of all about quadrants 1 and 3, in which individuals have low to moderate mental health or substance use risk and complexity, and either low to moderate or moderate to high physical health risk and complexity. And what we know, now I'm going to be speaking a bit on the mental health side to some of the same kinds of things that Connie has just talked with you about. We know that the general population has a prevalence rate of about 26% of having a mental disorder in any given year. And this particular study also was very important because it told us clearly for the first time how early cases start. Excuse me, with 50% of all cases starting by age 14 and 75% by age 24. What that particular piece of information means is that as we begin to think about integrated care, we need to think about this not just for adult populations, but definitely for adolescent and late latency age populations, and being sure that we are screening and thinking about risk as those individuals get their health care. In the case of this particular study, what we also learned is that of those who would need mental health service in any given year, 59% of those who needed treatment did not receive any services. And of that group who didn't receive any services, 80% of them had been seen in primary care in the previous year. So that represents a missed opportunity to have identified the need for mental health services and to provide some of those services. It's also important to note that of the 41% who received treatment, half of them got those services from the specialty mental health sector, but the other half got them from the general medical sector. So if you think about this whole pie that you see here of individuals who needed mental health services, only about 20% of them who were getting any services in the specialty system. It's one of the reasons we need to think about primary care as a different place for doing the work. We know that most physicians now do a good job of diagnosing and beginning treatment for depression. The rate of prescription use for antidepressants tells us that. But what we learn from studies like this is that they do less well in following up with treatment over time. And the key issue here is that people haven't completed a minimal course of medications or psychotherapy. They may well not have gotten the changes in medications that we know are necessary for people who are starting a course of treatment for depression. And the lowest quality of care was among those with the most serious symptoms, including those with evidence of suicide or substance use. So that really speaks to the need to develop collaborative care interventions in which we add to that patient-centered medical home team the staff that can help PCPs in following up with treatment over time. Similarly, we need to think about the prevalence of bipolar disorder in primary care settings. As the focus has occurred around depression, what that means is that some people have been identified as depressed but may not have been then subsequently screened for bipolar disorder. And you can see here in this study the estimate that the bipolar population represented about 27.9% of the depressed patients. So you screen for depression, and then about 28% of the people you've screened for depression may well have a bipolar disorder. And again, if we expect primary care practices to do this screening and adequate follow-up, we need to give them team resources to help respond to these issues in primary care. This shows us something that we all know, and that is there are very few people who only have one presenting problem. This is from a study in Washington State, and the overlay here is the most important message from this slide, that we need to be prepared to deal with chronic physical conditions and substance use problems and mental illness in primary care settings. The impact collaborative care model is the model that the National Council has been using in its collaboratives across the country, because what it provides is a structural approach rather than a diagnostic approach. It started with a focus on depression. It's now being used with people of all ages, and for depression, but also for anxiety, for bipolar disorder, for PTSD, and for substance use co-occurring conditions. And the key pieces of the collaborative care model are that you have a care manager / behavioral health consultant who's a part of the team in the primary care practice, and that team has access to a consulting mental health expert to help think about stepped care when patients are not improving as expected. The two key processes that are being used by those team members are systematic diagnosis and outcomes tracking. So using tools to do initial screening and identification of individuals with need for mental health services, and using those tools over time to track change in patient status. And step care being the changes in treatment that occur according to an algorithm if patients are not improving. And then finally, putting relapse prevention plans in place as a follow-on to the care management, the self-management supports that have been developed during the treatment period. These are from data are from the original impact trials, which were in 8 organizations across the country. The gold bar is the improvement in depression at 12 months. The white bar is usual care as it was delivered in that particular setting. So you can see in all of these settings, this structured model of assuring care got better results for patients in terms of depression. And one of the interesting things here, I don't know if Connie knows this, the circled set of bars, that was a Kaiser Northern California site that had a behavioral health consultant in the primary care clinic. So that's the white bar when you look at this. The difference is the structured model in terms of improvement in depression. So as we think about the person-centered healthcare home in terms of quadrants 1 and 3, what we want to do is incorporate those lessons of really thinking about the workflow and structuring the workflow to identify, track, and step care. And we have a really fascinating experiment going on right now in Minnesota, in which the Diamond Project is applying this model in primary care practices throughout Minnesota. And this is from a range of primary care practices that are quite small, all the way up to the Mayo Clinic. And what they have done is brought together all of the insurers, all the payers in Minnesota, and they are paying primary care practices a monthly case rate payment to cover the role of the care manager, BHC, and the consulting psychiatrist, the screening and tracking and stepping care activities. The data will be forthcoming about the impact on health costs, but what we know from early reports on this project is that they are getting the same kinds of results that you just saw in these earlier impact slides. This is the first moment to say, but we'll talk about it again at the end of this presentation, that all healthcare is local. So as you think about quadrants 1 and 3, what I've just showed you, what Connie showed you, working out the details of partnerships of who does what for what levels of mental health services is what the California IPI really set out to develop a framework around, and we'll come back and talk about that in just a minute. So this is the point that we're going to stop and let Victor throw some questions at us. And Victor, I'm looking at the time and thinking we probably can take about 5 minutes to do that so that we can finish the presentation and have maybe another 5 minutes of questions at the end.
Okay, well, you read my mind. So the first question, I think the one we got most frequently, which should be quickly answered, it has to do whether or not the slides will be posted and when the archived webinar will be available. I don't know if May is on the line who can answer that, but I believe it'll be within 48 hours of this presentation.
Yeah, that's my understanding. The slides will be posted quite quickly after the webinar is over with.
Okay. Well, we had a question from Josh, who, and I guess this was, I'm not sure who, it said, you mentioned making a case for integration. This seems to imply, is there opposition or resistance?
Oh, that's a great question.
Just how receptive is the audience when that case is being made, and what is some of the basis for the opposition, if indeed that's the case?
Well, let me tackle that and see what Connie wants to add to this. I'm presently in the process of writing a paper for CIMH called the Business Case for Integration, in which we're trying to pull together all of this research and lay out the arguments for why people should support integrated services. The opposition, I think, has frequently been around policymakers not knowing that mental health and substance use treatment works and that it can make a difference in people's lives and that it can also make a difference in health care costs. And so what they have seen is that this will be extra cost. We will be paying more to deliver more services to more people. So a great deal of the resistance has been simply around the issues of cost and whether or not we can, quote unquote, afford to add this kind of service capacity. Connie, what would you add to that?
I would agree with what you said, and what I would add is the issue of the primary care physician not having time to address these very complicated patients. They require more time. There has been lack of funding reimbursement for that, which, as Barbara points out, is maybe changing, and that is why a lot of the models that Barbara just described, and although I didn't get a chance to talk about, of finding non-physician providers to add to this care team really addresses a lot of the barriers that I have found, in Kaiser and also in some of the public programs that we've worked with.
Okay, thank you. There's another question here. Actually, I'm sort of focusing on questions that we have from multiple people, just given the time. But is there anyone in California providing patient care in a patient-centered medical home setting? And does this include mental health and substance use services? The idea being is, are there models around, within California that can be helpful for people wanting to take next steps?
So the IBHP project, the Integrated Behavioral Health Project, which is a co-sponsor of this webinar series, has been funded by the California Endowment for several years now to support a group of federally qualified health centers in adding mental health capacity into their settings. And some of them also have added substance use treatment capacity. I think more of the focus has been on the mental health side. So yes, there are models that are out there. There's currently a pilot project going on in the CMSP project that is looking in those counties at offering access to mental health and substance use services, and actually driven by the fact that they looked at their costs and said, oh, we have individuals here who need mental health and substance use services and they're not getting it. We need to think about doing a pilot to put those benefits into place so that they get them as well as health care. So yes, one of the things you will see if you go to the IPI report is a summary of a very initial scan of what the projects were that were currently underway in California.
Okay, and that IPI report is available on the CIMH website?
Yes, it is.
Okay. One last quick question here then. Hopefully a quick answer. This is from Raymond, who says that primary care providers don't screen for a number of reasons, don't screen for substance use, even after trained. In his area, that they've used special health advocates who screen and use motivational interviewing techniques to get better information, motivate behavior change, and motivate patients to accept treatment. Do you think that this very critical part of the intervention with the patient needs professional advocates, trained in substance use disorders, who can intervene and motivate patients to accept further services?
Connie, that sounds like it's for you.
Yeah, I think there really is a role for people with substance use expertise in these primary care teams. As I said before, I think primary care physicians don't have time. They're complex patients. I do want to reiterate, though, that we're talking about the full range of substance use problems in primary care, not just that tip of the iceberg that needs specialty treatment. And sometimes substance use professionals forget about those people and the less severe people. But I think having someone trained in to recognize substance use issues as part of a primary care team is very important.
Great. Well, thank you very much. Let's continue on with the webinar.
All right. Let's talk about quadrants 2 and 4. And I think, again, I would hope that most of you who are on this call today are aware of the fact that people with serious mental illness are dying at the average age of 53, mainly of health-related conditions. You may not know, however, this last piece of data on this slide, which is that when Oregon took a look at the morbidity and mortality of their population, they were able to sort out the difference between people who had a mental health condition only, a substance use condition only, or a co-occurring disorder. And you can see here that for those who had a co-occurring disorder, they were at the greatest risk, and their average age of death was 45. So for all of you who have struggled to think about how to address co-occurring disorders in either public sector or private sector settings, this really tells us how important it is for us to be thinking about bringing those pieces together along with the healthcare piece. This is data from Massachusetts. It's the data that actually got much of this discussion going about early death and chronic disease. And it was specifically looking at the rate of death from heart disease for individuals who were participants in the public mental health system with serious mental illnesses compared to the Massachusetts general population. And the quickest way to get a feel for what this slide is telling you is look at the age group 35 to 44. If you were an individual with serious mental illness, your chances of dying from heart disease between the ages of 35 and 44 were 5 times greater than that of the Massachusetts general population. One of the things that leads to cardiovascular disease and diabetes in all of us, this is not unique to people with serious mental illness, all of us are at risk for metabolic syndrome. And it's something that's increasingly being tracked because it's a precursor condition to developing diabetes or cardiovascular disease. And you see listed here the criteria that are used to assess metabolic syndrome. The important thing about the information here is that when comparing the patient population who participated in the CATIE study, who had serious mental illness with the general population, you can see that the prevalence of it was significantly greater among males and even more significantly greater among females. 51% of the females with serious mental illness met the criteria for metabolic syndrome. The other piece that they looked at when they did this analysis is how many people had active conditions, and so 88% of them had high cholesterol, 62% of them had high blood pressure, and 30% of them had diabetes. And of these individuals, they were not receiving treatment for these conditions. So that tells us that the issue of bringing primary care together with mental health and substance use specialty treatment is another piece of advocacy that we need to work on. Now, this is some data that's specific to California that was presented as a part of the 1115 waiver process. It had been developed through the CalMen planning process, and it helps us see in a more focused way what the challenges are in California. It tells us that of the people who are on Medi-Cal in the fee-for-service system, that while SMI beneficiaries are 10% of the population, the total costs of care, both mental health and health care, represented 37% of the payments. The comparison of the rate of chronic disease in the general Medi-Cal population and the population with SMI shows you that for every one of these disease areas, there is higher prevalence in the population with serious mental illness. And there also is a subsets of people within the overall population that we really need to focus our outreach and attention on. So what this set of numbers tells you is that there were in the Medi-Cal system in 2006 almost 250,000 people who had serious mental illness, and their average health care costs were $11,000 a year. But inside of that 250,000 group, there were about 28,000 people whose average health care costs were $34,000 a year. And inside of that 28,000 group, there was a group of 9,500 people whose annual costs were $50,000 a year. So as we think about developing interventions for addressing the health status of people being served in the mental health and substance use specialty systems, we need to be very focused about what the level of risk is in the populations and not just give everybody X amount of the same thing. We need to stratify our level of intensity for people who are at higher risk, because there clearly are subpopulations to be served here. The other thing that they did in this study was they said, okay, there are these very different pathways of how much care people received. What can we tell about the difference in those pathways? And they identified that the difference in per month cost was about $1,900 per month. What they found is that for people who were on the lower cost pathway, there were several things about the kind of care that they received that we need to think about as we plan for how individuals get served. First of all, they had access to rehab mental health services after hospital discharges. Their general practitioner expenditures and visit rates went up when they had a very difficult time in their chronic health condition. Their diabetes was significantly worse. They got more care. They had extended hospital lengths of stay. They got more care if they were needing it. They had a higher ratio of physical to mental health expenditures, inpatient care over ER care, and there was the continuous attention to medication adherence. The other things that lead to continued health, according to their analysis of the data, is people having access to preventive care, which many, many individuals currently have not had access to. And those preventive care factors are listed here, including, again, ongoing outpatient physician care. This is very similar to some of what Connie was telling you about in terms of supporting people who have substance use conditions in Kaiser, that people have ongoing outpatient physician care that is attending to their whole health, flu vaccinations, lipid testing for diabetes, and again, the uninterrupted use of medications. The knowledge that we need to have a better idea of what everybody's status is was what drove a piece of follow-up work that the National Association of State Mental Health Program Directors did to follow up on their morbidity and mortality report, which was done in 2006. And they've issued a report now about 18 months ago saying that everywhere in the mental health system, we should be gathering these indicators when people come into care, and then some of them we need to be tracking regularly. The ones we need to be tracking regularly are the weight, height, body mass index indicator, blood pressure, blood glucose, and lipid profiles. And we need to know over time whether or not those are getting better or worse for the people who are receiving mental health services, which is one of the reasons that we begin to talk then about bidirectional primary care and bringing primary care into mental health and substance use settings. We know from the literature that many people have no primary care provider. We know, and Connie showed you some data on health evaluation and linkage to health care can improve status. But we also know that on-site services are stronger than referral to services. If people can get that care all in one place, they're more likely to engage in it. And we're not necessarily talking about just bricks and mortar-based care, because there are some examples out there where housing first settings have wrapped around mental health, substance use, and primary care through mobile teams to serve people in those housing first settings, and have shown significant results in doing that. So person-centered healthcare homes, which encompass the tracking, the provision of primary care, can be developed through partnerships between mental health and substance use providers and primary care providers. And there is a webinar coming up in this series that is specifically going to focus on this question of partnerships. And throughout all of this notion of ongoing continuing care and care management is an important part of what it is that we need to build in. And this is really different work than the traditional case management work that has been done in the public mental health system, because it is focused on assisting people in managing all of the pieces of the complexity of their health status. The person-centered healthcare home then would have the regular screening and registry tracking that I've already reviewed with you. You would locate either medical nurse practitioners or primary care physicians in mental health substance use settings, and they would provide routine primary care services to people in those settings. You would, if you were using a nurse practitioner, also want to identify a primary care physician who is associated with a full scope healthcare home that has all the bells and whistles of the patient-centered medical home to provide consultation and referral on complex health issues. You would think about assigning nurse care managers to work with folks who have the most high risk around their diabetes, blood pressure, cardiovascular disease, other chronic medical conditions. You would figure out how to bring into the places that people come for care, access to evidence-based preventive care practices such as immunizations, such as cancer screening, and you saw in that earlier slide, eye exams, ear exams. And finally, there's a fabulous opportunity here to create wellness programs that use certified peer counselors as health coaches. And there's a number of examples of that going on around the country that we really can replicate to help people work on smoking cessation and nutrition and physical activity. So the care model is one of the founding ideas of the patient-centered medical home, and it says that you have to build a careful, integrated system that has all of these pieces: clinical information systems, decision support. You think about delivery system design. You build supports for self-management. You think about what the system of care resources and policies are that impact people. And in California, there's been added this idea of social inclusion and opportunity as being key. What you see in this version of the care model is that it has been laid out to think about issues that are specific to the mental health and substance use treatment system, so we can begin to talk back and forth with primary care using a similar conceptual model. So let me wrap up by briefly talking with you about the IPI report. The IPI report lays out a vision of that overall health and wellness is embraced as a shared community responsibility, and speaks to the need for us to work together to seamlessly integrate, plan for, and provide services at every level of the healthcare system, as well as coordinating with the supportive capacities in the communities. There are 10 principles laid out in the report that represent the shared agreement across mental health, substance use, and primary care participants in this process. And the IPI continuum is there as a clinical framework for community dialogue. This is just a shot of the first page of the IPI continuum. It's built on something that Intermountain Healthcare has been doing in its successful integration initiatives, and it reflects the fact that we need to plan for really 4 levels of care: mild mental health and substance use complexity, moderate, serious, and severe. And what it does through the whole continuum is describes the population, briefly, who is the population that we're talking about in each of these areas. It does some prevalence forecasting, saying how many people would be in the mild to moderate to serious to severe areas. It identifies the idealized set of services that would be available for each level of care, what some of the evidence-based practices are that would be delivered in each level of care, and suggests some initial ways to think about measuring results in each level of care. So you can work your way on down through the continuum and see these pieces. And throughout, it posits what the healthcare home physical health services are that should be made available for every level of care. Now, what we weren't able to do is to dive into what all the levels of healthcare also need to be. We were really focusing on trying to define the mental health and substance use levels for dialogue in local communities. And I think now we made it. We're going to have 10 minutes for questions, Victor.
Okay, well, let me, we had a question here. How well is integrated care achieved without integrated electronic health records? Seems difficult to do without shared records, but also presents confidentiality problems.
Oh, that question has got to be unpacked a little bit. So let's start with the confidentiality problems. In most integration projects around the country that are focused on mental health and primary care, the confidentiality problems are less difficult because of the provisions of HIPAA, which actually say that you can communicate with one another for the purposes of care coordination. And that's the umbrella under which the integration work then happens, is that you're communicating for the purpose of care coordination. Now, that said, many states adopted state-level legislation that tended to follow the construct of 42 CFR, which was applicable to substance use conditions. So in my own state, Washington State, the legislature last year changed state law in regard to mental health and stated it to be consistent with HIPAA, to say it is okay for healthcare professionals to communicate with one another for the purposes of care coordination. So every state needs to look at what either their law or their regulations say and think about whether or not they can change that for the purposes of mental health. In regard to 42 CFR and its restrictions on divulging substance use treatment, there is a national conversation, debate, I'm not sure what other noun to use, but there's a lot of talking going on about whether or not to change 42 CFR or to change the regulations or to clarify further what people can and cannot do. And it's recognized that that is an issue that needs to be dealt with. On the matter of electronic health records, certainly the ideal would be a shared electronic health record, but there are successful integration projects going on around the country where people are still working with paper records, where they've developed other mechanisms for communicating, the most significant one of which is if you're located right in the primary care pod, you are communicating constantly through hallway conversations, and that's probably one of the most significant ways to get information flowing back and forth. I know that SAMHSA just convened a work session last week to start looking at this issue of electronic health records and the confidentiality issues and how all of this could be grappled with in terms of integration. So it's a work in progress.
Okay, thank you. There's another question here. This actually, I'm combining for a couple of people, and this would be for Connie, where in your presentation you said that substance use treatment was provided when needed. And the question is, well, how is that defined when needed? And who determines this? And there was then the related question is, well, what kind of treatment was that? Was that provided by in-house by Kaiser staff or through referral to community-based substance use treatment programs?
Okay. In our studies, we actually interviewed people and gave them the addiction severity index. The way we are doing it in the continuing care model based in primary care is that it does rely, the primary care physician does have to ask. And they are supposed to be doing screening, and we do have it in the electronic health record now, and the vital signs ask about alcohol and drug use. And if the person, so that is when I say as needed, it means that the primary care physician has just asked the person, how are you doing, and, even about craving or whatever the patient brings up. And then the treatment is dependent, as I was, arguing that it depends on the severity. If someone says, I'm using a lot, then they get referred back to treatment. If it's an issue that the primary care physician can handle, then it's done right there. Or they call the substance abuse program for a consult. We're finding that that's a very popular thing to do. If they know someone, they can talk to for a consult. So Kaiser is doing its services in-house, but I believe this model can be done the same way in the public system with, as Barbara and I have been, mentioning, having non-physician providers right there in the public primary care clinic to provide that service for the physician just to be able to say, okay, I'd like you to talk to, so-and-so here before you leave. I also want to say that if anyone, all the data that I presented has been published, and so if people, when you see the the presentation on the web, if you want to email me for any papers, please feel free to do that.
Let me just add, Connie, that people may be interested in knowing that in Santa Clara County, they are starting a project of placing substance use counselors in primary care settings in the Santa Clara County system. So check in with Mark Stanford if you want to learn more about what's going on with that project there.